The subject of today's Global Health History Seminar is the UK, NHS, and universal health coverage. The Global Health History Seminar series was established in 2004 and is hosted jointly by WHO and WHO Collaborating Center of Global Health Histories at the University of York. Seminars take place once every month and are broadcast via the internet. My co-chair of Global Health History Seminars, Professor Sanjoy Bhattacharya, Director of WHO Collaborating Center at the University of York, is supposed to be here physically with us, but unfortunately he couldn't come to the seminar today because of the cancellation of his flight at Heathrow. So, but just now I noticed that he's in the webinar, so he's still with us. However, firstly, I'm honored to introduce our two speakers today, Dr. Martin Gorsky from London School of Hygiene and Tropical Medicine, and Ms. Veronica Walford from International Health Partnerships at the Health Systems Governance and Financing Department of the World Health Organization. Each of the two presentations will last for about 25 minutes, followed by the Q&A session for both speakers. Kindly remind everyone to speak into the microphone and give your name since the seminar is broadcast. The first speaker is Martin Gorsky. Dr. Gorsky holds a BA in History from the University of Essex and a PGCE History and PhD Social History from the University of Bristol. He joined London School of Hygiene and Tropical Medicine in 2003 with the Wellcome Trust of University Award. His main research interest is the history of health systems with a reference particularly to Britain, and his early work was in his histories of sickness insurance and hospital financing before the National Health Service. His recent projects include reconstructions of mobility trends since 1850 using sickness insurance data, analysis of medical officer of health reports for London in the interwar period, and a study of the pursuit of equity in policy making in the British NHS since the 1970s. Dr. Gorsky, please.
Well, good afternoon, everyone. It's an honor and pleasure to be here speaking to you today. I think if you asked any British person what they see as the core principles of the NHS, it would be the universalism, the fact that all citizens and some categories of foreign visitor are covered, its comprehensiveness, famously providing a full range of services from cradle to grave, and with some minimal charges, the fact that it is free at the point of use, funded principally, but not entirely, from general taxation. What I would like to do in my talk is first discuss how, in 1948, Britain reached this point of universal coverage, how it moved from a very pluralist health economy through a Big Bang reform to this highly stated Minister of Health under the Labour Party, Aneurin Bebin. In the second part, I'll look at some of the ways in which historians have approached the theories of comparative health systems development to see how Britain may have got there. Here, perhaps, we can find some lessons or at least issues to talk about from that history. And in the third part, I'll talk about how under the NHS, Britain went on from the basic universal coverage to try to fulfill Bebin's founding promise of universalizing the best, in other words, improving equity of access and quality. So to begin, and I want to begin with civil society in the 19th century, because it was here that the groundwork of the British health system was laid. Hospitals, essentially funded by middle-class philanthropy, the centres of biomedical development and of acute care, where free access was established as the norm. And sickness insurance, grounded at the grassroots of working-class culture, in small clubs, meeting in pubs or ale houses, where people would subscribe a small monthly sum, called a friendly society. And this would give them access to sickness benefit, and increasingly in the 19th century, to a doctor. The local state was there as well, from the 1830s through the Poor Law, providing workhouses, institutions for the impoverished, which in effect provided long-term care for older people, very largely. If you know your Charles Dickens, you'll know that these were generally of poor quality and carried a stigma. It was dishonourable to enter one of these institutions. Local government, too, had a role in public health from the mid-19th century, the era of Chadwick, of sewers and drains, environmental health. But increasingly in the century, clinical activities as well, where the focus was on certain notifiable infectious diseases. And then, 1900s, in comes the central state, the birth of Britain's welfare state, a period which saw, for example, the establishment of old age pensions, school medicine, and so on. But our interest, 1911, health insurance. Today, I think we would call this scaling up. Essentially, the government took the existing friendly societies, but made it compulsory for working class people in particular to join them. It split the cost as well between the employer, the employee, and the state. The benefits remained the same, a sickness benefit and access to primary but not hospital care. So, next question. How does Britain move from this pluralist mix, philanthropy, neutrality, local state, national state, to the National Health Service? The story is usually told firstly through the financial challenges faced by the voluntary hospitals, as demand and rising technical costs meant that philanthropy was inadequate, and a mix of user fees and contributory scheme payments outside of national health insurance was introduced instead. And that, of course, provoked the question, well, why not just unify into a single system? As for local government, popular opinion was changing towards the stigmatizing elements of the Poor Law as new notions of citizenship took hold. It was the period when the term social welfare replaced the idea of the Poor Law in this sort of policy area. So increasingly workhouses, at least in major cities, were transformed into hospitals. And the clinical powers of public health departments in local government were also expanded. Maternity care, childcare, clinics, and so on. And finally, the national insurance system proved a great success, but in its success led to calls for expansion. By the late 30s, it covered about half the British population, but infuriating for middle-class families on incomes slightly above the maximum, who had to pay commercial rates. And also it excluded people, because it was a payroll system, excluded people outside the formal workplace, women particularly outside formal work, children, older people, and so on. So all these things together, by the late 30s, led to a growing consensus in favour of some kind of reform. But I think we have to accept that the catalyst, the real driver of change, was war, an unpredictable juncture, if you like. Two things. First of all, the government established an emergency medical service, a state-controlled hospital system set up to deal with the anticipated casualties of the military and civilians which war and bombing brought. Secondly, it occasioned a political shift. The social solidarity of wartime deprivation cut through the existing class politics which characterized the British scene. And as the population looked forward to a new world after the war, so a faith in planning and optimism about a planned welfare state began to gather traction. And the Beveridge Report of 1942 crystallized these ideas. It's famously the blueprint of the British welfare state, and Beveridge, an academic, promised to slay the 5 giant evils: want, ignorance, idleness, squalor, disease. There's only a few pages about a national health service in this long report. He didn't plan it or really suggest the structure. That's a mistake that's often made. But he did state that it was needed. So this political window opened and was then made possible in 1945 when a left-wing Labour Party won a substantial majority at the election. And this allowed Bebin to carry through the NHS legislation, which previously had been really stuck in debates between the interest groups. And so this diagram here shows the model of the NHS, which obtained in its first couple of decades what we might call the Bebin Model. This is the establishment, really, of universal, comprehensive and free service. And there's a few things to note, please. First of all, it's an integrated hierarchical system where ultimate power and responsibility lies at the top with government, with the Minister of Health. Local democracy, whether through civil society, committees, etc., or through local government, is now gone. Accountability to national parliament replaces it. The funding stream similarly sort of comes down from the top. The Treasury collects and then dispenses to the regions based initially on precedent. You got what you had spent before. There was then a tripartite structure which unified the disparate parts. The hospitals, now nationalised, were under regional hospital boards with their own separate committees. Primary care, similarly, under a separate group of committees and not linked. Only a rump of public health was left in local government, its clinical powers now taken away. There had been a proposal initially that health centres would be developed, and these would provide a linkage between preventive and curative health. That was the promise, at least, of Bebin's plan. So this is how it looked. This is the arrival of universal coverage and the model system which Britain adopted. So now let me talk a bit about how historians have tried to explain this. Partly this is generally how they explain the development of welfare states, and I'll try and locate Britain within that general approach. And so the first observation is that welfare has followed modernisation, and it was the wealthy countries that were in the vanguard of establishing these things. This graph, if you can make it out, shows that quite nicely, I think. You've got year on the y-axis, and then each of the data points are the year at which a country first established a form of social insurance. Not just health insurance, it might be old age pensions, it might be unemployment insurance, but it's a marker of when a welfare state, as we now understand it, begins. And so here at the bottom, Germany, the forerunner, Bismarck, with sickness insurance and unemployment insurance. And if you can make it out, you'll see that in the first 30 years or so, it's really Western Europe and some of the white ex-imperial dominions that are the ones who go first for this initiative of social security. The x-axis is an index of modernity, the percentage of the workforce in agriculture. And if you can make it out, you can see that Britain at this stage is one of the most economically advanced parts of the world. A low proportion of its workforce still in rural pursuits. But it's interesting too to notice that it isn't the forerunner. It comes slightly later than the vanguard. And actually this was a general finding, that there is no simple and necessary relationship between stages of development and point of adoption. Certainly yet it's context, but there is no sort of trigger point or threshold, if you like, which determines the adoption of the social security approach. So another aspect of modernisation that was pursued was democratisation, because in liberal Western Europe, this was proceeding at the same time. This works quite well in the British case, because following the legislation in the 19th century, when the suffrage, the vote, was extended, we see public health legislation follow. 1872 is the first articulation by a prime minister in Parliament that the health of the people should be a first political duty. And I deceived you earlier when I showed that illustration. In fact, it comes from a political poster. It's saying, in fact, that health is a party political benefit, which you will get if you vote the right way. There are problems with this theory. We can find more authoritarian societies which get there earlier, and we can find highly democratic societies which get there later. So it can't work really as a general explanation, no matter if it works for Britain. Marxist sociology, very popular in the 1960s and 70s, gives us some possibilities too. One thesis, the labour mobilisation thesis, proposes that it's trade unions and labour parties which lead. That doesn't work very well for Britain in 1911. They were actually quite ambivalent about health insurance. A more plausible thesis is the legitimation argument, that ruling classes in government conceded welfare to essentially pacify a rising unionised population and growing labour parties. Perhaps that could work for Britain. Labour mobilisation, I think, does work a bit better in 1945, because it clearly was a Labour Party which brought the NHS in, and I think its features, like the nationalisation of hospitals, progressive taxation, can, I think, be attributed to those political characteristics. A more popular theoretical approach recently has been political institutionalism. And this argues that essentially the timing and character of welfare states is dependent on a particular national governing structure. And in the British case, we can say that everything was in favour. Early on, it established a professional, transparent civil service appointed by exam. There was bureaucratic expertise in health early, the Chief Medical Officer, the Ministry of Health, and so on. And as the tax base broadened, income tax, local rates, so citizens began to feel an investment, a participation in the state. And British legislative institutions, too, were particularly suitable for passing a deep, controversial reform. The system often gives clear majorities, allowing government to carry its will. A strong party whip means internal loyalty is usually guaranteed, and there are a few veto points at which interest groups can block things. And I particularly like this cartoon of Bebin forcing the bitter soup of the National Health Service down the throats of the doctors, the British Medical Association, who were his opponents. Final point, ideas, political culture. And it was the case that at the elite level, by the turn of the 20th century, sociology, social surveys, investigating poverty and ill health had begun to shift beliefs around it, revealing the structural and environmental causes, and moving away from the classic liberal tenets of individual responsibility in favour of collective responses. And finally, just to come back to where I started, remember that at the popular level, people were already used through civil society organisations to free healthcare from hospitals and from participation in mutual associations to paying small amounts for their insurance coverage. So that quickly tours some of the theoretical approaches. Perhaps there we can find some issues to discuss about implications for other societies undergoing such processes. Let me now move to my final section to quickly survey some aspects of the National Health Service and talk about how it's moved on from universal coverage to, in Bebin's words, universalise the best. Bebin, in fact, hoped that there would be a small period in which a backlog of demand was met, and then the NHS would reach an equilibrium of relatively stable spending. But like all societies since the war, that was proved idealistic. And in fact, Britain, like everywhere else, was soon experiencing rising real health expenditure and a rising commitment from the economic product of the country. One thing that did become clear fairly quickly when comparative data were examined was that the NHS was a comparatively cheap health system when set against countries like France and Germany, which had used insurance as a route to universal cover, and certainly against the United States with its much more pluralist mix of services. And it's easy to understand why that should be, with the government, the agent, the single payer, if you like, able, through the Treasury, to sort of put a cap on overall health expenditure when economic policy, economic necessity dictated. Of course, comparative figures also raised doubts about whether this was good cost containment or perhaps underfunding. But because, until quite recently, these comparative outcome figures were quite crude, British policymakers were able to say that actually the underfunding case was not proven. The figures were grossly simplified, and always argued, even when Britain did come out worse, that actually there would be ways through greater efficiencies, etc., of improving performance. It was really only about 15 years ago, as better data, disability-adjusted life expectation, amenable mortality, cancer survival rates, and so on, began to raise some real doubts about a British lag, that an underfunding case started to look more plausible. And some critics, I'm sorry, I don't have a pointer, but some critics attributed this to what was a long period in the 1980s and 90s of Conservative Party hegemony, in which the average annual real percentage increase in the NHS budget was kept down, was kept quite tightly down over a fairly extended period. So we got Labour stewardship in red, Conservative in blue, the various changes in the British electoral system. And so you can see a broad consensus in the early period around the growth of the welfare state, the health services, the consensus in the 1970s, the oil shock, fiscal crisis, that it needs to come down, but then a long period subsequently where expansion is really held back and only stopped in the 2000s as the Blair government comes in, new Labour, and decides to increase. So cost containment or underfunding? It's an interesting historical question. Beyond that, too, there were various planning devices and approaches that could be taken to extending the reality, if you like, of universalism. The 50s and 60s saw planning implemented. As for hospitals, there was a slight improvement in things like regional distribution of specialists. And in the 60s, a new plan was developed to build a whole new network of general hospitals to replace the infrastructure. Broadly, that was only at best a partial success when it came to the reality. Primary care remained the weak point in the system. The health centres fell foul of austerity post-war. But again, in the 1960s, a new family practitioner contract, better pay for doctors, support for administration and so on, led to an improvement in that sphere as well. Things get interesting in the 1970s. This is the period when the golden age of growth comes to an end. Labour returns. It can't expand the finances, so it looks at different sorts of policies under, again, a left Labour minister, Barbara Castle. And this is the point, too, where health economists begin to appear in the bureaucracy. And some of the interesting approaches they developed, well, first of all, the RORP. This was a method of allocating the overall finances, not any longer by precedent, but according to a new weighted population formula, which tries to address need and make funding follow need. Deprivation comes in there partly as one of the considerations. And again, you'll be peering here, but this seems to work, at least at the regional level, in that there is quite a narrowing of gap between the regional allocations of funding, at least if you leave aside 2 London regions which are sort of recalcitrant. It's also the period in which program budgeting, an effort to distribute the resources more fairly across the programs, again according to need, and essentially this means shifting it away from acute hospital care towards more services for community, geriatrics, long-term sick, mental health, and things like that. And again, so that seems to have led to sort of slow and progressive change. Labour also commissions a report into social inequalities of outcome close to the end of its tenure, and that does indeed prove a very clear social gradient in ill health, but nothing happens because it lands on policymakers' desks when Mrs. Thatcher and the Conservatives are returned to power. So now we enter this period of the restraint in NHS growth. The Conservatives they consider but reject privatising the whole service, and they aim instead to introduce new management disciplines to try and tighten efficiency and effectiveness. And you see the beginning really of more diverse performance indicators to allow authorities, right down to the level of hospital departments, to advance efficiency that way. A more interesting policy is developed in the 90s, the internal market. It follows partly ideology, the belief that by injecting demand and incentives into a statist system, you can improve performance, but it comes also from international policy learning. That is Alan Enthoven, the American who was developing the ideas of managed competition in the context of US health maintenance organizations. So both those things are driving policy, which leads to a so-called purchaser-provider split. Primary care becomes the purchaser, later commissioner of services from quasi-independent hospital or community trusts. The historical verdict on whether this has really improved things, well, it's quite debated. It's not really certain. I think there's general agreement that putting primary care more in the driving seat has been a good thing, but whether any outcome improvements can be directly attributed to the policy is a lot more contentious, because of course you also saw a slight uptick in the finances to grease the wheels of this reform at the time. So we come finally towards the present and new Labour, and remember this is the point at which the funding boost comes in as the centre-left returns to power, and the political mood at the time favours a third way, not back to old statist Labour, but a kind of midway between state and market. So essentially the Blairites maintain the Thatcherite approach, the Thatcherite recipe, although purchasing now becomes commissioning. Private finance is brought in to develop the hospital sector. But the state is also used in new ways too. There's a regime of targets and audits for hospitals and publication, open publication of their performance in league tables to try and incentivize improvement, targets and terror. The British model of health technology assessment, NICE, is also introduced early in the Labour period, and I think quickly gains an international reputation for its approach. And like many other countries, the state also leads with tobacco control legislation. So I'm really out of time, but I suppose where I'm heading with a kind of provisional historical reflection on the NHS since 1948 is that there is this interesting debate about whether the model leads to essentially a very cost-effective system, or one which is vulnerable to underfunding with negative effects for outcomes and satisfaction. And also I think there's evidence of some interesting approaches within this public integrated model, particularly once the health economists enter the scene of devices within the NHS format to actually advance equity alongside cost containment. And I'll just close with this, the Olympic ceremony from a couple of years ago, when Britain quite literally paraded the NHS before the world as a symbol, really, of the nation. And I think what that speaks to, the affection of the people for it, are these sentiments of social justice and health security. And so I'll just close with a quick extract from a book by Bebin, the founder, where he essentially epitomizes his ideal of health security, that a society becomes more wholesome, more serene, and spiritually healthier in the context of universal health coverage. Thank you very much.
Thank you, Dr. Gorsky. So the second speaker today is Ms. Veronica Walford. Ms. Walford is an economist by background and mainly works on health planning, financing, and aid effectiveness issues. She worked on UK health issues as well as education and wider public sector reform issues in the 1980s. Since the 1990s, she has been working in international health, including at country level in Africa and Asia, and on global initiatives as well. Since the middle of this year, Veronica has been working in the core team of the International Health Partnership based in WHO. So, Ms. Walford, the floor is yours, please.
Thank you very much, Jing, and thank you, everybody, for coming, and thanks to Martin. Can you hear me? As Jing just mentioned, I've been most recently working in international health, particularly in Africa and Asia, and so I'm going to reflect a little on what we can learn from the UK system towards universal health coverage and how that could apply in other countries. I think it was raised earlier, but just to remind you in terms of the definition of universal health coverage, that we have three main strands to it. It reaches everybody, it's equity, it's universality. It's about access to good quality health services, that people have the services that they need. And then it's about financial protection, that people have financial access to services without it pushing them into poverty. So I'm just going to make a few comments on each of those areas, on how the UK NHS model tries to tackle some of these issues. So equity, and Martin highlighted that essentially all UK residents do have access to the NHS. It's not linked to how much you've contributed or whether you've contributed. You have it by being a resident of the country. And there's been a big focus on trying to improve equity and access. Martin mentioned this. The terminology is about ensuring equal access for equal need. So it's about how trying to actually address, it's not just equal amounts per capita, for example, in the allocation of resources, but actually looking at health needs. And those are the kind of issues there which have been taken into account in developing the formulae for trying to improve health needs, allocation of resources to become more equitable in terms of health outcomes. So what do we see from that that's relevant to other countries? This issue of reallocating resources, like many other countries, the UK found when they looked, and Martin showed a graph, that some areas, but particularly the capital city, London, has much more health resources than some of the more remote areas, and in our case, in the north of the country. So while there was a policy and mechanisms like these formulae to try to reallocate resources to the underserved areas. In fact, it's taken 30 years and we still haven't fully got there. It's much more difficult to do this. It's quite easy to work out a formula, but to actually then shift resources, you can usually only really do that in the context of a growing budget, where you can put some of the growth into the underserved areas. It's very hard to take money away from an overserved area or people away from an overserved area and get them to go and live and work in the less well-served areas. It's an issue in the UK just as it is in other countries, although there has been some progress and that gap has narrowed. We still see, for example, that the number of GPs relative to population is lower in some of the more deprived areas, even in the UK. We see after this period of having access to services throughout the country, we still see inequalities in use and we still see inequalities in health. And I illustrated that. That's just a picture of the inequalities by deprivation, just to show one way of measuring it. We have something like a 9-year gap for men in life expectancy between the most deprived areas of the country, that's number 1, and the best off areas of the country, number 10. So we still do have inequalities. The fact that there is access, financial access and availability of services and everybody's covered hasn't resolved all those problems, and that will continue to be the case. Of course, that's partly because demand is different. It's partly because access to health services doesn't mean is the only factor in improving health. There will be many other things in people's lives that will affect their health, and low incomes, poor food and so on are part of it. Another equity issue in the way that the service is run in the UK, essentially the principle is everybody gets the same service within the NHS. So you can't, even if you want to, you can't top up your by putting some extra money in, get a better service through the NHS. You can go round and go to a private service, that's different, but there's no mechanism for topping up and getting a slightly better services. And I think that's the philosophy of equality, that everybody should get the same service that drives that. But the result is it limits how much funding is being spent on health. And there is, people might be willing to pay, but in a way they're not allowed to pay for extra services. What about the services themselves? I mean, it's very noticeable how highly public sector our system is. Various governments, as Martin was saying, various governments have tried to bring in the private sector in terms of financing hospital construction and actual delivery of elective services particularly, and increasingly other services. But the vast majority is public services. Technically, some of them are not. For example, general practitioners are actually contractors, not public servants, but essentially they are publicly funded and on contract to the public sector, so they're pretty much public services. And this allows for planning in the services. We can look at allocating resources rationally, not having duplication and so on. And it also leads to this sense of it being our NHS, and I think it was well illustrated by the pictures from the Olympics, that it's sort of perceived as a national service. Some of the implications of that, one is this very large public sector workforce of the health service. It's something like 1.7 million workers in the National Health Service. And that, according to which set of figures you look at, it's around the 4th largest employer globally. So it's a huge employer, and which has quite a lot of implications for how you then manage the system and what you can do with it. In terms of you can plan, of course, because you're the employer. You can set personnel policies across the country, and that may not always be ideal because your conditions will vary across the country, and skill shortages in one area and not in another. You can't very well respond when you're running everything as a national service. So it has quite a few implications in that way. We've seen this effort to bring in private services has been very controversial in Britain. There's always a lot of resistance to it. And privatization is, but for many people, a dirty word in the context of the health service. It's kind of a confused debate, I think. People confuse between public funding of services, public provision, and there's a lot of mistrust around any moves in those directions, although it is happening in practice under both kinds of government. We do see quality is an issue, as in absolutely any service in the world, and for a long time that was expressed in terms of waiting times, that you had to wait a long time to get treatment, but also more recently there were sort of scandals on the quality of services. There had to be a complete reorganization and reconstruction of the quality assurance mechanisms, and it continues to be an issue really in how to keep up quality in a largely public sector, just as it is in other countries. But even in a well-funded system as ours is, in relative terms, this is a continuing issue. And finally, the issue about provider payment mechanisms, whether it's public or privately provided services. The provider payment mechanism seems to be the key way you can use to try and push up performance and try and improve quality. And these are being changed sort of every few years. Some new initiative comes in. So you've had capitation mechanisms, you have payments to do with reaching coverage targets, you have payments to do with how quickly people get seen and those kind of issues. There's a continuing process of refining and changing to get the mix of incentives that will try to improve performance. There's a lot of experience there about different mechanisms you can use for that purpose. Financial access, this is the issue about nobody needs, essentially you don't pay to use our services at all. There's a very small co-payment for some people, but for the low-income people, they don't have to pay anything at all. The net result of that is that demand is high. People are not reticent about using services except for the sort of time costs that they face. But in financial terms, you don't think twice about going, it'll be too expensive to go. And that leads to structural changes or structural design of a system to try and control costs, because you can't rely, if you like, on charges being a deterrent to use. And probably the key mechanism is the GP, the general practitioner primary care level, as the gatekeeper to secondary and tertiary care. So to get any kind of hospital care, apart from emergency care, essentially you have to go through a primary care and get referral. And that's quite a strong discipline. It's quite hard to get around that system unless you go outside the NHS. So that, that it's a consequence of very good financial access is then you have to have the other mechanisms in place to manage demand and to control costs. Financial protection, I think you could say we score quite well on this because it's a tax-based system. People pay when they're working, or they pay through the other types of tax, purchase, sales taxes and so on. You don't have to pay when you're ill. The fact that when you're ill, even if you're off work, you still have access to services and so on. So we do, the tax-based system has the benefit of being financial protection, and so does other kinds of social health insurance, of course. And perhaps the difference here is that one difference is that how much you pay depends on design of the tax system, not on, for example, how much you earn. So it can be progressive. It depends on the tax system more generally. It also means that the amount that's spent on health is a political decision as part of a national budget allocation. So the amount for health is not, there's no earmarked amount for health in what people contribute. It's entirely a matter of the national budget process, which makes it a very political decision. The fact that it is a sort of hot issue came up. We've just had in what we call the National party conferences in the last month in the UK, and all the main political parties made a statement about how much they would put into the NHS in terms of funding allocation if they get through in the next election, which is next May. They've all said they're going to spend, how much they're going to spend, or going to spend more, or some of them, one of them actually said how much more they would spend, the others were just vague about that. But it's such a political issue that it comes up even well before the election, how much you're going to spend on health, and it's an important question for the electorate. So it's a consequence, if you like, of it being a tax finance system that you get that kind of political debate around the level of finance. We're not, so where are things now and how far are we towards universal health coverage? I think what we see is that we have good financial protection. Over 80% of the spending on health is through the government, which, if we look at WHO's recommendation, would consider that to be good financial protection. I wanted to just compare it with some of the other countries. Sorry, I have a note here. We could compare that, say, with Switzerland, where it's 62%, UK is 83%, Switzerland is 62%, USA it's about 48%, Germany 76%. So, you know, it is among one of the higher countries in terms of ensuring financial protection. So the rest, the proportion that's not publicly funded, would be then funded out of pocket or through private insurance. Woo. That was such an earth-shattering comment. Caused the whole projector to explode. I'll keep going because I've virtually finished. This is basically my last slide, so I'll just keep going. Shall I do? Just continue, yes. I was also going to, I think Martin's raised the question about health spending as a proportion of GDP, and this debate about, is it an efficient system, and that's why we're spending relatively less than some of the other countries, or is it that we're under-investing in health and we just don't have enough health care? And that debate will continue, I'm sure. You know, our performance is good on some measures and poor on others, so it's hard to say. But we're certainly, I think the UK is spending about 9% of GDP on health, which compares with, say, 12% in France or 18% in America. So we're relatively, like, low spenders. And as I say, the performance is somewhat variable. We face sort of rising needs and demands with an aging population, with non-communicable diseases, with new technology, and just with public expectations. And that's really a strain at the moment because we're in an austerity budget period again. We've got pretty much a static budget over the last few years and probably limited growth in the coming years. So there's a huge financial stress, which is sort of, in some people's view, coming to a crunch. And those sort of pressures, those cost pressures, are going to apply in other countries, even if it's not an aging population. I think the other factors apply to most other countries. The political visibility of the NHS, I think, has played a part in protecting the budget allocation. If you compare it to, say, other parts of the public sector which had to face much greater cuts, whereas the NHS, the budget has been secured at a sort of static level, which is sort of good in an austerity time. So the fact that it's through the tax system and is very politically visible has contributed to the sustaining it to the extent it is sustained, although how long one can stay in that situation is what's difficult to assess. And as I say, it remains a very hot political issue. All the party conferences had these other promises on health, promising about access to GPs at the weekends or in the evenings, you know, different positions on that, different positions on how to use the private sector in the provision of services. So it remains a sort of hot political debate about how the private and the public sector work together in health. And just a small quote from one of the newspapers a couple of weeks ago says, "The desperate struggle for votes is at least forcing the parties to begin to address the funding shortfall and the need for big investment in primary care." So as in other countries, this question about how much resources you put into health and where they'll come from, how they'll be, what the allocation will be, continues to be a hot issue for us. So I'm going to stop there.
Thank you, Veronica. I'm very sorry for the accident, and but the PowerPoint of both speakers will be available on WHOJH's website. So maybe afterwards, if you're interested, you can always have a look and access to it. So now it's the section of question and answer. Maybe we will take 1 or 2 questions every time, and then after the speaker gave the answers, then we can move on to the next round of questions.
Yes, Socrates Litzios. Martin, could you say something more about the failure of the health centers? Because it seems to me at that point in history, health centers were the wave of the future. WHO and its public health administration expert committees were looking to health centers as really being, at the lowest level, primary level, the core place where integration would take place. And if, with England failing, that might have suggests also that that model would be less appropriate for the rest of the world than the other kind of models that might have had health centers that were really working that way. Thank you.
Presentations. The UK National Health Service is one of the, my name is Shiva. The UK National Health Service is one of the best models of a working health system, of course supported by political, social and other support, which I think you presented very well in the end. But the UK has a large influence on how WHO provides policy and direction for national health systems in many parts of the world. And we still see this dichotomy of multi, plural, and state. And many of the countries in Africa and Asia are always struggling to build a state health system, but the support is not coming, whether it is from the UK or others, because of the dominance of the US model. How do you address that?
Well, thank you very much. It was a very interesting presentation. I like the history of the NHS. But this is a comment, and I would like both of you to comment on that as well. It is very reassuring that the population of the UK has taken ownership of the NHS. And I believe this is one of the most, and you have said it as well, one of the most important assets of the UK. However, we see more and more ads for private insurance companies on television all the time. It's a massive perception of that. So do you think that people, are inclined or being influenced to purchase the private health insurance? And do you think this will change the perception of the population from the NHS? Thank you.
Shall I start with health centres? Because I think, yes, clearly in international health, in the interwar period, the health centre model was absolutely key to new thinking about rural health in Eastern Europe, in China, and so on. And my actual view is that the health centre idea, in an important way, does originate in Britain. Again, on the political left, the Socialist Medical Association was particularly keen to advance that idea. And I talked about local government public health in the 1920s and 30s. And in London particularly, but some other cities, this was an arena where the health centre model was tried. It was a way of bringing together the clinical public health services like maternity, child welfare, sexual health, and school medicine. There was also a very celebrated example in South London, the Peckham Centre. This was a voluntary private initiative, but it was meant to be a sort of total health experience with leisure facilities, swimming pool, classes, and things like that, as well as resident doctor. So a kind of holistic health model. And as I said, in the NHS plan, Bebin's idea was that public health would be brought back to clinical health within the health centres. What's happened first is that in the immediate post-war period, because of austerity and recovery, a huge proportion of Britain's housing stock was damaged in the war, for example, and the education system was also expanding in the early welfare state. The NHS was a casualty of early investment. It just didn't get it. And then the Conservatives returned to power. The health centre model was seen as something associated with the left, and that the medical profession did not want it. The BMA, they were against it because they thought it would mean the doctor would become a public employee, a salaried employee, instead of an independent contractor, which, as Veronica explained, is still their status. And so, as proposals were put in local authorities to develop these things, in general, approval tended not to be given by the government. So instead, that model of the large polyclinic, if you like, that didn't happen, and it came instead through a sort of mix of state support and private development of doctors, seeing the appeal, the rationality of joint practices, but on a smaller scale. And what that's meant is that as recently as 2007 in London, where there is still a very high proportion of single practice GPs, there was a call in a report from Lord Darcy for a polyclinic system to be introduced. So it's something, a great idea present in the early 20th century, which never really bore fruit. We'll go on to WHO. Would you want to? Okay. So on the question of Britain on the international stage, it's something I haven't really thought a great deal about or worked on much. I do know that in the early years of WHO, there were some debates about whether health services, and particularly health financing through social security systems, should be a prime focus of the organisation. And I think there were different groups at that time, in the period between 1948, early 1950s, which took different positions on it. And I think really there was an Anglo-American access, which argued that at the early stage in WHO's life, health services ought really to be left to the individual countries. It was essentially, you know, their role. Nonetheless, there were certainly factions within British public health, people who followed the social medicine philosophy, who took a very different view. And my sort of reading of the early period is that health services kind of took a back seat as the big eradication programs of the 50s and 60s, smallpox, malaria, polio getting going, and so on, came in instead. In the 1970s, the period of Alma-Ata, there was then a moment of the window opening again around basic health services. And in fact, I've just been doing some reading in the library about this today, and it seems that Britain's chief medical officer here on the executive board of WHO was making the argument that this was a direction which WHO should take in the period leading up to Alma-Ata. I know less really about the more recent period, but I would agree with the observation that US Washington consensus, if you like, that a mixed economy of healthcare with user fees being used, insurance being used as a way of pushing forward at a time of restrained member contributions was the way to go. Reading some of those early World Bank reports, which recommended that new direction in the 1980s, you can certainly see some British names, some British economists who were reading those things, and of course it's British health economists, some associated with my school, who've done the work more recently, which has shown that user fees in some cases have proven to be barriers to access. But beyond that, I think that in the later period, Britain, I don't think, had a real sort of leading role in sort of pushing independent policy on health systems. But other people may know more about that.
Yes, perhaps just to add on the question of the roles of public and private systems and provision. In a way, having had a big public system, the UK system is moving towards more of a mixed system, than both public and private, and a formal contracting type relationship between them, and the challenges that brings. And that's what we've seen happening essentially in some of the lower income countries, where the state funding has been too little to allow the public system really to be the mainstay of health services, and the private sector has filled the gap. So we're getting a more consistent evolution, if you like, towards a mixed economy in most countries, I would think. I was just going to comment on your point about advertising of private health insurance. And in the UK, there's been private health insurance around for a long time as a sort of minority area for relatively better off people, and some employers also fund it for their staff so they can come back to work more quickly. I think it's used for elective surgery quite a lot. It's used for things that the NHS is not keen to do or doesn't consistently do well. I think a lot of the population feels that if they had something serious wrong with them, they will go to the public sector, they will go to the NHS. That's where most of the capacity is and the best provision is. So it's almost more of an added extras, the private health insurance. And also you don't have the option to opt out. You pay your tax anyway, and that funds the public system. So even if a chunk of the population does pay this extra money for the private services, whether through insurance or out of pocket, they don't have the option to opt out. And I've not really seen any pressure to say that you should be able to opt out. The issue comes up with education more often than it does in health. So there's the acceptance that we all pay, if you like, through solidarity payment for the basic health service. So you may be right that in the end it will undermine, but at the moment I don't think that's the threat. Do you, Martin?
Yeah, just to sort of put in a bit of the history of private insurance. I mean, right from the beginning of the NHS, actually, there was a place for private insurance. And in the negotiations Bebin did to establish the health service, the doctors held out for continuing private practice, and therefore private insurance was maintained. And in fact, the hospital contributory schemes I described became the basis of a very low-cost health insurance called cash plans, which developed in the 1950s when the first co-payments were mentioned. They were for eye care, and for dentists, and for prescription charges. And so these low fees allowed low-level health insurance to get established and to continue on a non-profit basis. In the 1980s, the Conservative policy was to try to bring in more private health insurance, and that was the point at which it was encouraged, I think, through tax incentives. And I think then something like between 8 and 11% of the population, something like that, went for private health insurance, but mostly as a work-based incentive. And it was really, I think, used as a way that employers could attract employees in particular branches of the economy, and really has never advanced much further than that in Britain, because it isn't a very good deal when you have the alternative of the National Health Service on offer. And I think that's really where it rests at the moment. As for the issue of purchasing or commissioning from the private sector, that has been settled policy really since the 1990s of both parties. Labour's position was that, again, it would follow the Thatcher idea of a sort of mixed market of contracting. It started really with ancillary work, you know, the service side, the hotel side of the hospital, and then gradually broadened to include clinical work. Labour's view, I think, was that it was worth having as a sort of an option, but it would ensure through its sort of hierarchical controls that it was always a fairly limited percentage of the market. And what's happened under the coalition government and the new legislation is that it's been very much opened up, and that sort of notional cap on the scale has been removed. And the idea now is that any qualified provider can be the provider of services. And the government wishes actually that to be not just private firms, but also non-profits. They want, in a way, to revive the mutual model, which I was showing deep in history. However, the data that we have so far, and it's only really for about the last 2 or 3 years, is that where contracts have gone outside the NHS, it tends to be the private sector firms which are getting them rather than the third sector.
And the first question will be the question from webinar. So my colleague Mira will read the question.
My name is Dermot Marr. I work with the Tropical Diseases Research Special Program. My comment is about the relationship between the NHS and research and development, which in general terms is absolutely crucial for driving health improvements. It seems to me that the NHS has got some special features in relationship to research and development, namely that a lot of research and development takes place in part integrated with the provision of care through the NHS. So this has at least 2 big advantages. One is that as developments occur through research, they can be very quickly scaled up, made widely available to the mass number of the people receiving care through the NHS. And then the other advantage is that the link between researchers and the work of their clinicians working in the NHS can be very fruitful. So sort of 2 good examples, perhaps 2 of the most outstanding medical advances in the past 50 years came from what you might think are slightly unlikely places in the northwest of England. The artificial hip was pioneered by Mr. Charnley in Wigan General Hospital, and the test tube baby, Louise Brown, was born in Oldham General Hospital in the early 70s. And those collaborations really came about through interactions between very eminent researchers in universities and other academic institutions and NHS specialists working in district hospitals. So just appreciate a comment from both of you on what are the special features of the NHS in relationship to research and development.
Okay, the state, I'll speak historically. The state in Britain has always had a slightly difficult position as a commissioner of research, because back in the early 20th century, something called the Haldane principle was established, which was the notion that the state should appoint research councils and give them a budget, and they should be sort of quasi-independent bodies which should actually take the decision about the direction of research. In other words, that it should be arm's length, and that academic freedom should be a sort of key principle rather than the state bureaucratically leading. Well, fairly soon in the history of the NHS, some difficulties arose with that, because the Ministry of Health, it had a small research budget, and it actually came from the charity endowments of the hospitals, which were allowed to remain with the teaching hospitals, so they held a little bit of it. But it was also permitted for charitable research charitable funding to go towards research. And then the department itself had a very small amount. But actually the questions were then raised fairly quickly of actually the ministry does have some special needs, not only to promote clinical research which it is interested in, rather than just leaving it to the academics, the blue sky thinkers, but also particularly over health services. Actually, a computer program back in the 1960s was one of the big issues on which this turned, but also just basic efficiency of hospital management. Health services research, we now talk about it as a part of the furniture, but really it just was beginning to emerge in the late 1960s and 1970s at the same time as health economics. And at that point, there was a change of thinking in the government, and a much more direct control of the research budget, which had hitherto been given to the research councils, was taken by the department. And at that point, it sort of took off. So the 1970s is the point where a really sort of clear drive from the centre is something we start to see. But it covers everything, not just the sort of clinical innovations you were describing, but the needs of health services administration as well. And since then, it has really been a tussle between the state, who would like to direct, and voices in the academic community, the research councils, the science community more generally, who would like not to have such direct leadership. And it's been very interesting. It often turns on issues like how much money should go to the teaching hospitals. And when I was describing the RORP, this effort to adjust resource allocation more fairly across regions and away from London, well, of course, London could say, but we need it, because this is where the teaching hospitals and medical research is all centred. So it's been a sort of long-running tussle between the community, the health research and government communities throughout the period.
Thanks. Hello, my name is Fran McConville, and I'm in the Department of Maternal, Newborn, Child and Adolescent Health. Thank you very, very much for those talks. And I just wonder, what historical lessons can we learn when you talk about Bebin's view on the setting up of the NHS and the objection by doctors to engage in it? Because I think that tension still exists to some extent, we know, with the way that the GPs are funded. But for other countries who are looking at different mechanisms, we know that the medical associations and others, as in the UK, are hugely politically powerful. And sometimes we're finding that that is, perhaps a bit of a block, or that the thinking kind of stops where it is. So I just wonder, how did Bebin do this? How did he get it through? Was it the movement of people and the idea that it was a social welfare program?
Okay, I mean, I don't think there's a lesson of history, sadly, which is going to be applicable everywhere, but it can certainly, I think, sharpen our thinking to reflect on Britain. Bebin was lucky because actually Lloyd George had already broken the doctors' opposition in 1911. You're quite right that if you look across the sort of international examples, we often find organised medicine as an opponent of what they see as the incursion of the state. There's, I think, a perfectly reasonable and genuine argument about clinical autonomy, that if the bureaucratic state is going to step in, directing research, etc., then that infringes a precious right of scientists and of doctors to diagnose, prescribe, etc., as they see fit. But of course, you can't disentangle it from the financial right to charge as they would like, and also their employment conditions if they become effectively public servants. And they've never really wanted that. Now, in Britain, Lloyd George was fortunate, actually, because Britain was a quite heavily doctored nation. The balance between the numbers of doctors and head of population was unusually high compared with other countries. So it was a competitive labour market. And for many new doctors coming into the profession, and if they weren't from fortunate elite families where they could cruise to a hospital consultancy position, then they would have to establish a primary care practice. If they wanted fresh ground, if you like, it meant going to a more deprived rural area. You were describing the inequalities of provision. And there, of course, they would have more difficulty building a viable financial practice because their families were poorer. And indeed, it's the big cities, the seaside towns with a lot of retired people, the nice county cathedral towns where doctors tended to be centred. But it was this competition that really split the British Medical Association at the time of 1911 and meant that they didn't stand as a united front because some of the doctors who were in a more difficult competitive position could see the advantage of a fixed salary. Not salary, well, they got a capitation payment under national insurance. Another point is that back in the 19th century, under the friendly societies, where they were engaged as club doctors, they were essentially answerable to a committee of working men, and I use men advisedly. It was essentially a sort of male committee of the friendly society which would run it, and they would be having to answer to those people. And this, of course, for the medical profession of the 19th century, when they were establishing themselves as a respectable, high-status, middle-class activity, this was something which was quite undesirable. So they could see advantages, in fact, in the state system, or at least enough of them could. Now, once the national insurance system began in the 1920s and 30s, most doctors began to make a mixed income living, relying partly on national insurance payments and partly on private fees for things like childbirth especially, and other people in families who weren't covered. So when we come to 1945, 1946, when the debates are all ongoing, there was certainly a proportion of the population of doctors which were sort of ready to go with it, but Bebin certainly faced very strong opposition. Again, on the same lines, that doctors didn't want a state service, they didn't want to become state employees, and so on and so forth. Well, actually, Bebin made quite a lot of concessions. The doctors, the GPs remained private, independent contractors. Private medicine was allowed to continue with private wards in hospitals, and so on and so forth. But otherwise, Bebin's view was that, well, if they continue to object, we'll just do it. And I'm sure that they gave in before, and they will do again. And that proved to be what happened. The protests that the doctors wouldn't join the NHS, it never occurred. And since then, one of the problems was that the hospital consultants were promised good, reliable salaries. They could see the money would be coming in to the hospital sector, and that their lives were likely to get better. So again, there was a division within the BMA. As to how this applies to other countries, well, obviously the locus classicus is America, where the American Medical Association has been much more successful in fending off and really sort of leading the opposition at the various points when national health insurance was proposed there in the 1910s, in the 1930s under the New Deal, in the 1940s in the Truman era, and indeed the time of Medicare. And there, I think, what I call the institutionalist argument really matters, because you have to focus on the points in your legislative process at which hostile groups can veto, even if there is notionally a sort of popular majority in favour. And I think Obama probably had sort of learnt from that. However, he was favoured in the recent episode because essentially the health maintenance organisations, rather than the state in the American case, were now sort of threatening to curb clinical freedoms as well. So in a sense, that stance of the doctors on perfect autonomy had already sort of gone in the US context.
We have an online question from Indra Patmanathan, International Medical University, Malaysia. What mechanism does the NHS use to determine how much to pay specialists?
I don't know specifically about specialists, but there is an independent pay review body which reviews the payments for doctors, for nurses, and I presume also specialists. But it's essentially a negotiated process.
Just following on from this idea of the power of the medical profession in and the kind of dominance of curative medicine, hospital medicine over primary care, and one of the main contributions of this inflation of unsustainable growth in the health budget as a proportion of GDP. I just wondered, in the National Health Service experience and the centralization of control, has that, you've already discussed some of the difficulties and the opposition of the medical profession, but has the National Health Service managed to, in some way, increase primary and preventive medicine as opposed to other systems? And is it being successful in that or not? Is it falling into the same problems in other countries?
Okay, well, I mean, thinking historically first, I think it's true to say, I've never really done the numbers, but that Britain must have come into the National Health Insurance, National Health Service era in a very fortunate position, because actually the development of general practice as a sort of mode of medicine was already very well established, and I think that kind of differentiates it anyway from some other countries in that you could train, you could get a professional qualification as a licentiate of the Society of Apothecaries, which would mean you could practice professionally with a sort of combination of sort of basic surgical skills and a sort of lower level diagnostic and prescribing skills than a sort of fully trained physician. And that meant that what we now talk about as general practice, primary care, the physician's office, the physician coming out to do the domiciliary visit, that was something already well established. And then, as I was saying, this massive development of the friendly society network through sort of mutualism through the course of the 19th century, it really goes from the late 18th century when Britain begins industrializing, and you find it's in the industrial sort of heartlands that these things really take off and then spread. Friendly societies, first of all, engage doctors to essentially vet the members to make sure they weren't taking, the adverse selection was avoided. And only later were they actually beginning to be employed to treat the members and get them back to work. But through that sort of rather circuitous process, a form of funding primary care quite broadly was developed, and I'm sure that was quite an important part of the spread, if you like, of general practice. However, with all that said, to come to your question about the balance of primary and hospital care, I mean, I think this has been a sort of ongoing story, and I think my comment about the purchaser-provider split theoretically empowering primary care is quite an important one. But on the other hand, the 1990s gives a very good historical example of the essential failure to really shift the balance of power. And actually London is the focus, because London becomes the pressure point when the resource allocation changes start to really kick in and take money away from the London hospitals. And in the late Conservative period, in the 1990s, there's a series of reviews. What should we do about London? And there's a lot of talk that we must build up community services, we must give primary care more sort of scope for innovation, we must invest. However, the result always seems to be that the hospitals rationalized. There were periods of hospital closures. There was a great debate about whether to close the ancient celebrated St. Bartholomew's Hospital and so on. The medical schools rationalized through mergers. And then somehow the despite all the energy that they're called health action zones in the 1990s, despite all the energy that goes into that, and some real innovation with health centres, actually. There are some that are trying to recapture the sort of holistic notion of the health centre that Peckham pioneered. But despite all this, it often seems to be the case that the old status quo balance of power kind of returns. So I think it's, but you know, of course, at the moment, as the looming sort of impact of sustained austerity, which you were talking about, confronts us, again, you know, there's a lot of talk about primary and community care is where we must push services.
Thank you very much, Dr. Gorsky and Ms. Walford. I'm afraid that we have to close the seminar today. Thank both of you for giving us a very comprehensive and clear picture of National Health Service in the UK, as well as the implications and the areas that the universal health coverage covers and its important components. So thank you all for your participation to the seminar today, and we are looking forward to seeing you again on the 19th of November. Thank you.